It's my really great honor to introduce and welcome Steve Levine, that you must all know about. And today, he will unify all what we have seen today in the different organs and unifying a virtual human community. Please welcome Steve Levine.
Thank you. And first, before I start, please give me a big welcome to Nicolas Picuchet. He's not my virtual twin, but he is better looking and younger, so he's got that.
Back.
All right, well, thank you all. Hopefully, like me, you've been changed by the last day and a half. I often walk out of these meetings with a new level of inspiration that carries me all the way through the beginning of next year. I think about what I'm going to do next year while I'm in this talk. I listen to the brilliant minds that I've heard here, and it gives me so much encouragement for the future. What I'm going to talk about now for the next few minutes hopefully captures what I hope to do for the next year, and I've called this a call to action. Hopefully it resonates with what you've heard over the course of the last day and a half, or 2.5 days if you've been here. And it really is a societal requirement, a demand for us to coordinate our efforts. Something that science has always tried to do through the tools that were available, mostly through the written word historically. So you would publish, peers would review it to make sure it was of sufficient quality, and then you would try to validate it, replicate it, and try to coordinate their effort. We now have something far more powerful, and that's the virtual twin, and hopefully you've started to see this. So I'll try to synergize what I think we've heard and some of the ideas, and really, again, this call to action that hopefully we'll find ways to enable. So if you think about what we've been doing as a community, the virtual twin community, really the entirety of the healthcare community is kind of captured in this dilemma that we have this systematic research effort here on the left, shown here, organized by scale. So people, as you know, we often think about the problem at a different level of scale. And we have this gap in between what happens in the laboratory and what happens in the clinic. And that discussion happens a lot here. One of the unique things is we find a common language. But historically, when you get to this level, from the tissue level into the organ, it's where the animal models have really historically come in. And then you have this gap. And the NIH, this is one of their graphs, they call this the valley of death, because so much of the funding that happens to get to the organ or system level is in an animal, and then it turns out not to be representative of the human. And we find that out very expensively. We heard from Milan, the failure rates in clinic. We heard from Kevin in medical device, it's more than 50%. In drugs, it's 90%. That model doesn't really work. And so our goal was to see if we can actually build this with human models. Now, we have the potential to get rid of that valley of death. So instead of a 90% failure rate, we could have a 90% success rate. Why take something to a clinical trial unless you already know it's going to pass? Filter it out so we don't spend all that money. We don't put all those people through that much pain. It's possible, and I think that's what we should be striving to do. Now we know that, and we talked about this a lot, that another approach to that, which we're seeing a lot today, is kind of the brute force big data approach. Well, let's just take this data, bring it all together into a big database, apply machine learning and artificial intelligence, and then see what it tells us. Problem is, it works sometimes, it doesn't work other times, you don't know which is which, and it doesn't really yield any understanding, and we've heard this word come up a lot, trust. And in healthcare, we need to have trust. And if you don't understand something, you're not going to trust it. And that's always been a foundation since we've been working on building these. We heard it was beautiful segue I think Kristen said seeing is believing. People need to understand what it is before they can see it. And I share this quote. I love this slide that I put together. But sometimes I describe the Living Heart Project as just the way to understand how something worked. Like the heart, we had to build one. It's very different when you have to build something. The level of understanding, the way the human mind begins to process something, if you have to build it, then you can understand it. Dr. Richard Feynman, Nobel Prize physicist, he basically famously said, in fact, that was on his chalkboard at the time of his death. He taught all his students, if you can't create it, you don't really understand it. And we heard this gap between the medical world, who are not taught how something works because they don't have to build it. Engineers are taught to build things, and that's why they learned how things understand. It's that gap that we look to bridge. Now, it isn't that AI isn't very important to us. In fact, this slide, which is now, I believe, about 8 years old, which captures a collection of the different application areas that the Living Heart has been used. And down there at the bottom, AI and machine learning has been in there from the start. We found out very early on, in fact, working with the team at MIT here in Boston, that the virtual twin models were an excellent way of training the AI because it's comprehensive understanding of how something is functioning in the language that the computer understands. By putting clinical data or medical data in there, there's a translational layer that goes from the real phenomenon, the human body, to the human understanding of the phenomenon, to then what we've captured, and then feeding it to the machine. And we've lost a lot of information in the translation. By feeding it the virtual twin, you eliminate all of that translational issue. There's an amazing amount of information. And that content really came to bear when we realized that when we started to overcome this bridge, we couldn't directly go from organ models to human data. We found this is where AI became an extremely powerful tool to be able to go from a finite set of models, and you heard a number of examples about that over the course of the last day and a half, to a population. And this is really magic. And the amazing thing was when it really came to bear was in the least obvious place was, and you've heard about this, was when we worked directly with the FDA to overcome that bridge. When I first started working with them, they couldn't imagine how we could go from a finite number of real patient data to an entire population, thousands. They're like, well, you couldn't do thousands of different patients and then test every one of them and go through that, computationally too much demanding. And I said, well, that's where AI comes in, and they were very skeptical until they weren't. And as I think we heard from Dr. Rizzo, and from Kristen, you can actually standardize this methodology if you have a good training set. And they realized that rather than using the judgment, as we also heard, you ask 10 doctors, you get 10 different reviews. The AI can actually work as a standardization where you can build agents that can be checked, that can be validated, and can be reproduced. And that was, I think was transformational in terms of certainly my confidence that this was the accelerator we've been looking for to be able to go from handcrafting to the volume and the democratization. Interestingly, and you've seen, I don't know if this graph was shown, this version of it, but that population right in the center, this is the diagram that's in the publication. You've heard some of this the other day. Starting from clinical data, building that training set, so put all your emphasis, making sure you have a good foundation, then you can create whatever population you want very quickly, and you can do whatever you want with it. and you can check to make sure it works, because you can go back and recreate the virtual twin that AI is producing and saying, is it giving me the right answer? So you have this closed loop. And interestingly, as I think was mentioned once, it was this application that led this past year. So even though the Living Heart Project's been around for 10 years, Fast Company named it one of the top ideas that it's changing the world in 2025. So it wasn't until we married these two technologies before our work, I believe, got the proper recognition for what it really, for the impact it has, because it can scale. And that really matters, as long as you have a good foundation. Beyond just the general recognition, we all know, so this is an announcement of the information coming directly from the FDA. I worked with them, of course, on the enrichment project. So this is a publication from this past April in the drug side, where they're basically saying they're asking for AI-based computational modeling evidence. And in fact, if you read it in detail, they'll actually accelerate your trial or your review if you produce this. So they're incenting the public to deliver AI-based computational modeling data. To do that, the NIH is following. So this was 2 weeks later. The NIH said they were going to prioritize human-based research to figure out how to bridge that gap. I was fortunate to be in Washington, D.C., and got to meet with some of the folks at the NIH. And in fact, later that year, I met with Nicole, and we talked about the limitations of animal models. She pointed out at that time 90% of the NIH budget was going towards animal models, and thus the valley of death. We talked about how to bridge that. 2 weeks later, they announced they would no longer fund any project that only used animal models, that wasn't geared also towards generating a human model. So we have the government now supporting us, believing that this is a new generation. So we really have all the pieces in place to take this next step. And we've heard a lot of the foundations here today. We also heard from the clinical world. I share this graph. This is actually quotes from Dr. Partho Sengupta, who would have liked to have been here. This was from a presentation he gave 3 years ago at the conference. And his vision so he's the head of cardiology for Robert Wood Johnson Medical Hospital in New Jersey, which interestingly turned out to be where my daughter was born. I've talked about her. So I have a great interest in helping his department be successful, but he shared his idea for the future of cardiology. He believes that the way it's practiced today is no longer relevant to the way we live. And he had this idea of a kind of a control room, a cardiac control room. So by the time the doctor sees you, you've had your scans, you've had your data, all your sensor information has been processed in a control room. They've analyzed it. So when the doctor comes in, he's already had the analysis of your virtual twin. So now he has a conversation with you with the process information, because there's a team of people in the back room supporting him doing that analysis. It's kind of the next level of evolution of what Dr. Hoganson's doing on a patient-by-patient basis, but doing it on a uniform hospital-wide basis where they're actually processing technology using the twin. Because we collect this data, it's digital. Technology is here to do this today. We've also heard about the importance of sensors. This is a little small, you probably can't read it, but on the left, this is a report from the US Government Accountability Office talking about the essential enabling technology of sensors for driving virtual twins in healthcare. So this is considered a strategic asset at the US government level. I suspect similarly in Europe and Asia. But we now know that this is really on the radar, and they're really looking to us to provide credible pathway to actually make it happen. Now, how do we do it? I like to show this graph because we're here at a big community. There's a vast virtual community that stands behind us. And here we are 11 years later after we started with this very small group. And I alluded to the conversations I had with Tom early on. How do we build a group that could scale to hundreds? Imagine, we have over 160 organizations collaborating, sharing critical information about patients, about intellectual property, about their products. And in 11 years, we've not had a single problem with sharing of data. And part of the reason is we organize it properly, and I show these two types of models. And on the left is kind of a traditional consortium where everybody is sharing information in a common pool. And the problem is, as that group grows, the trust goes down because you don't know who's looking at your data. Whereas on the right, what I call the hub and spoke model, we acted as the hub. We have a one-to-one relationship with every partner. So as that grew, we still have a one-to-one relationship. So the trust is in the hub, and then as it grows, you maintain it. And then at some point you have a critical mass, which we have, and of course the benefit then is you can identify optimized collaboration, so smaller groups that, and we see this happening at every meeting. I'll see 3 groups working together and find out there's a new project been inspired because common pieces come together. And so we have a sustainable model that works, which was part of the goal of the HEART project, was to define a template that could work for our space. And we have that now, and what I actually see as a kind of a living environment. It's actually continuing on its own. So we have sustainability and constantly changing collaborations. Every year I see new ones emerging. And I think we can take this and scale it. That's my hope. And so my goal for this is to look out and say, can we make this scale to the human body? If we look back in 2015, we kind of defined the space of the virtual twin with the heart. We had one model, wasn't very complex to manage. 5 years later, we started developing multiple. We've seen communities across the organ levels here represented today. We have others. They're starting to go. By 2025, you can read the publications. There are digital twins and virtual twins of organs coming everywhere. And now with AI, we're going to be able to generate these hundreds and thousands of them. And the question is, what is now the future? And I believe there's 2 paths for our community that's been developing, still operating in isolation. And I just call out these paths. So we're either going to organize in a way that nature has already given us the blueprint for, and we heard it in, for example, in the work coming from the lung team saying, well, we should be marrying the lung and the heart together to have a system. And the liver should be part of that. And oh yeah, by the way, the kidneys need to be part of that. And the brain is controlling it. And the body has already given us that template. So why are we operating in independent? Why are we developing kind of in the mode of what's down below? And because this is where it goes out to be. Either we're going to end up handing off to the healthcare people this collection of models that don't work together, or a system of systems. So each of us, and we've talked about, has our digital twin, our virtual twin partner, because we can choose from those models and they all work together. And I think that's my hope and my wish for this community, is that we choose the top path. And we take this moment, which I believe is a real inflection point in our, and potentially dividing point, where we either choose to move in the upper frame together, or we continue to isolate. And as you can imagine, if you know me, I'm all in on the top round. And so that's what I'll be spending my time on, helping to organize the communities together coming out of this. And hopefully, if you've been here and listened to the different groups, you realize the commonality between the different teams. They may be at different levels of maturity. They may be solving different problems, or medical problems, but the healthcare problems, the computational, the organizational problems, all are common, and we can share that information. So I'd like to end, so here's the view that hopefully we'll be able to build, focus on next year, establishing teams against all of the strategic, the critical organs, all of the key systems, and try to define a way that they can all work together. So if you're interested, after this meeting, I'll try to put a word out and see if we can get a community together and start to do some planning associated with this. And then, if we do that, we can do a much better job of addressing this problem, because now we have we replace that valley of death or that disorganized pot of information with something that's actually organized in a way that nature has already given us the blueprint. And then we can have a trustworthy AI platform that can be efficient for everybody, and that information is being fed, the same information is being given to the research community and being given to the medical community and back and forth. And now we have a continuum that's centered around the virtual twin. So that's my hope. I'd like to end on a story. And as you know, I try to keep everything I say as real and understandable as I can be. I tell the story. A lot of the inspiration that I get and knowledge comes from the journey of my daughter, which I show here, in her journey from being patient to scientist to now doctor. She's now, as you see, MD, PhD, neurologist, pediatric neurologist, solving one of the most challenging medical areas, working at the top program. And I shared this slide last year. This comes from her application. I particularly called this out because this was in her MD, PhD application, the wisdom of a student. And she pointed out that her calling really came from the combination of her biology and her life experience. And we talk about experiences here, and sometimes people just think of it as a word, but it's really essential. It's how we learn, it's how we express. Those experiences are really, and they guide everything. And I'd like to share, since technically we call this Science Week now, its longer term is actually Science in the Age of Experience, and this is the Virtual Human Twin Experience Symposium. So I thought I would share another view of her experience going from patient to scientist to doctor, but showing it in terms of her heart, because I've told the story of her heart, and we've heard from a number of pediatric cardiologists and the challenges they have. And so what I'm showing here is her life in terms of age. On the top, her education level and what she was going through at the time. And on the y-axis is the experience of her heart in terms of the percentage conduction. So all of us are born, most of us, it conducts 100% of the time. It works perfectly. For her, by the time we noticed and measured, by the time she was 2, it was about 85%. At which point they said, okay, well, it's already starting to degrade, and it's a progressive condition. It will only get worse. So this was her progression. Got her first pacemaker at 2, her second pacemaker at 8. You can see the conduction's going down, the third pacemaker, fourth pacemaker. And by now, she's in medical school. So, and you can see her trajectory. This is what her heart, the trajectory for her heart's life, and her choice of what she's doing with her life. She's continuing on this path of what is ahead for her, undaunted by the fact and the trust that we would keep her alive. And this was the point in this scenario where I launched the Living Heart Project, and you all helped make it happen. And we started to learn about how the heart works, and she started to learn about it as being a doctor, a PhD, sharing what I was learning about her insights. And all of a sudden, things continued going down, and I started to get, at the point where she's starting to completely fail, and they told us about 30 was when we'd need to be thinking about a new heart for her. At which point, we're working very closely together. I don't have a lot of time here to go through everything that we went through. What I can share is the clinical record, which here she is in medical school, residency. This is what then happened. Her heart repaired itself. As I said, I don't have the time to go into the detail. Happy to share it with you. But what I can tell you, of course, she had access as a doctor to all the medical professionals, all the treatments, the drugs, whatever she needs. She could test. I had the insights and the team. What I can share is the number of treatments and drugs she used to have this turnaround, 0. Not a single drug. The power of understanding and knowledge, lifestyle, understanding, getting the data that she needed. And so what I call this, instead of science in the age of experience, this is what I call experience in the age of science. And this, I believe, is the experience that we should aspire to give to everyone, to help healthcare be done this way. And so I'll end on this quote, which I think really captures the spirit of what we've heard today. Never doubt that a small group of thoughtful, committed citizens can change the world, because indeed, it's the only thing that ever has. So with that, I thank you all.